Good afternoon, everyone. My name is Terry. I'm the marketing coordinator for Texas Orthopedic Specialists, and welcome to the webinar hosted by Dr. Sara Suttle, Your Common Foot and Ankle Questions Answered. A little bit about our practice real fast. We are Texas Orthopedic Specialists. We're a group of fellowship-trained orthopedic surgeons and subspecialized doctors. We provide North Texas with comprehensive orthopedic and sports medicine solutions. And we have offices in Bedford, Keller Alliance, and Denton. Now, before I introduce our wonderful speaker, Dr. Suttle, I want to give a quick shout out to Texas Health Southlake. They have co-sponsored this event with us. And before I move on, I'm going to toss it over to Jenny Lanier. She's the marketing director for Texas Health Southlake, so she can say a few words about the hospital. Give me 1 second, Jenny, and I'll pull you up.
Thank you so much for being here. We are so honored to be sponsoring this webinar with Texas Orthopedic Specialists, and so thankful for Dr. Suttle for being here with us today. We are a multi-specialty hospital. We are located right next to Central Market, across the street from Southlake Town Square. We are proud to be the first hospital in Southlake. That's something that many people don't realize, that we've been here for about 16 years now. We do have a 24/7 emergency room. We serve over 18 surgical specialties. We have 3 physical therapy centers, and so we offer a variety of specialties, and I encourage you to please check us out at texashealthsouthlake.com. You can learn more about all of our physicians and all the specialties that we serve. So thank you again to Texas Orthopedic Specialists and to Dr. Suttle, and I will go ahead and turn it back over to Terry. Thank you.
Thank you so much, Jenny. And we'll go ahead and move on to the next portion of our webinar. Let me introduce Dr. Suttle. So Dr. Suttle is a foot and ankle specialist here at Texas Orthopedic Specialists. She specializes in injuries and pathology of the foot and ankle. She's board certified in foot surgery and rear foot and ankle reconstructive surgery by the American College of Foot and Ankle Surgeons. And before I toss it over to Dr. Suttle, I'm so sorry, I forgot to mention that if you have questions, utilize the questions section of this webinar. There should be a little tab where you can type in any questions you have for Dr. Suttle. And at the end of her presentation, we'll open this up and start going through those questions. And she may go through some of them as we go along as well. So feel free to ask any questions about her talk as we go along. Okay, so now I'm going to go ahead and toss it over to our wonderful speaker, Dr. Sara Suttle. And give me 1 second, Dr. Suttle.
You ready?
Yes, are you ready?
Yeah, I'm ready.
Did you get it all figured out?
Yes.
There she is. Okay, thank you, Dr. Suttle.
Yes. Okay. Thank you guys for joining us today. I am Dr. Suttle. Like Terry said, I'm a podiatrist or a foot and ankle surgeon at Texas Orthopedic Specialists. I've been here in the community about 10 years, maybe a little bit longer. So some of you may already know me, or already maybe my patients, and just tuned in to ask some questions. And then some of you guys might be new and just have a question about foot and ankle needs that I might be able to help you with today. So I put this presentation together just to kind of go through some common foot and ankle things that people come into the office with. And certainly I couldn't get all of the common stuff, and there are some other diagnoses. So please sort of just listen. If I answer your questions, great. If I create questions, and ask those to Terry, and then she'll relay those back, and we'll get all those at the end of the presentation. But this is more supposed to be a question and answer, so you guys can come to me and I can sort of have a forum here to answer your questions. I love doing that in real time, in person, but this pandemic has sort of limited how we're able to communicate. So I kind of want to keep this as a raise your hand, ask the question kind of webinar best I can. So again, thank you all for tuning in, and I'll get started. What is a podiatrist? That's a big question I get. People look at my initials and they'll see DPM and they'll go, what does that mean? You know, so doctors of podiatric medicine is a DPM. That's what a podiatrist is. And we pre-specialize in foot and ankle and lower extremity pathology. So we go get our bachelor's degree and go to medical school just like everybody else. But in the last couple of years of medical school, we have pre-specialized into foot and ankle. So then we do a 3-year surgical residency for foot and ankle surgery. I'm having some technical difficulties. I guess you guys can't see my slides. I thought I had done all that. Let's see if this works.
Just click that. Oh, cancel. Don't quit now. I'm so sorry, guys. Allow the apps. I guess it does by clicking that, so it should be good, right?
Just click that.
And then maybe do later.
And then just close it.
Yeah, that should be. I think that's working. Okay, sorry about that, guys.
It doesn't have.
Oh, it's not lit. Okay,
Is that better?
Yes, that should work. Sorry about that.
I'm going to have Terry make sure that you guys can see my slides now. Sorry about that. The first one was just a title slide. You didn't miss anything. So again, it's just a pre-specialization of a medical specialty. So I do the bones of the foot and ankle and then all the soft tissue up to the knee. That's what podiatrists do in the state of Texas. Okay, so we also do surgery. As Terry mentioned, I'm board certified in foot and ankle surgery, but I'm also board certified in rear foot and ankle reconstructive surgery. So that includes all the stuff that you might know about the feet: bunions, arthritis, hammertoes, soft tissue, nerve things, skin things, nail things, but also trauma, and then of course diabetic foot care stuff. So a wide array of specialties.
All right, so just backing up a little bit, there's the first slide about what a podiatrist is, the initials there, the DPM. And then again, kind of the list of the things that we do as far as bone, joint, ligament, tendon, everything that has to do with the foot and ankle. Some doctors are just bone doctors, some doctors are just vascular doctors, some people are dermatologists, but as a podiatrist is unique because we treat all of those things as it pertains to the foot and ankle. So one of the first, not Paul Bunyan, one of the first common diagnoses that people ask me about are bunions, and that's big toe joint bunion. And so as you can see on the screen, there's a bump on picture A there, and a lot of people will go, can't you just shave that off, you know, like it's a calcification or something like that. It isn't though, as you can see in picture B, it's actually a deviation of that joint. So the first metatarsal starts to drift over, and then I don't know, can they see my arrow? Okay, I don't know if you can see my arrow. Okay, so, and then the proximal phalanx here, the big toe, this would be the big toe portion. So the first metatarsal moves this away, and the toe starts to move this away. So it's actually a deviation of the big toe joint. So the bump you see over here is not calcification, it's actually the joint. So if you just shave that off, you would destabilize that joint, create a bigger problem. And you can kind of see this is the second toe, the third toe, the fourth toe, the fifth toe. So you kind of know what we're looking for. So a bunion sometimes doesn't hurt. Some people don't have pain with these, but they'll start to get this sort of toe crossing over situation, and they'll come in with second toe joint pain or third toe joint pain. And it really is only there because the bunion. So when you talk about fixing or stabilizing these, you have to make sure that you address the underlying problem, which is the bunion there. So bunions are a really common problem. I see those a lot. Again, they don't always hurt, and if they don't hurt, we don't do anything about them, but they certainly are a common problem. So here's just another picture. This has a little cartoon of what it looks like to fix one. So you actually make a cut in the bone and shift it back over so that you align that toe back up. I had a patient who so graciously allowed me to use her clinical pictures and x-ray pictures so I could kind of show you guys what that looks like. So this looks like that first picture I showed you where this bone is moving this way and this toe is moving this way. Hers isn't quite as bad as the original, but see, she's got sort of some stuff built up here. So we clean all that off, and then we make that cut as the cartoon showed across there, and then shift it over and hold it together with a screw. This bright white thing is a screw. So now you can see the joint alignment is perfect, the toe is straight, and after the bone heals, the screw stays. We don't typically take them out, but it holds the toe straight. So her her surgery was obviously successful here. You can see that the joint itself looks back to be in good alignment. Hammer toes, that's another common problem. You will see a lot of them in the second toe, especially associated with the bunion of the big toe joint or arthritis of the big toe joint. And then some people get them unrelated. And so hammer toes are actually where the tendon along the top of the foot, if anybody has any knowledge of sailboats, it creates a windlass mechanism. So this tendon inserts at the tip of the toe, and when it pulls stronger than the tendon on the bottom, it buckles the toe upward as a windlass does. So a hammer toe is one joint, a claw toe is the end joint, and a mallet toe is the end joint, and then a claw toe is both. So some people have hammer toes of both of the little joints in the toe. So hammer toe is a general term we use if there's a buckling or a clawing of the toe. Those go from flexible to semi-rigid to rigid. So when you stand up, they flatten out, but when you're relaxed, they sort of bend up. That's flexible, usually no problem. And then when they become more rigid, like this gentleman standing here, and they stay clawed up, sometimes they'll rub in the shoe. They'll become painful, like arthritis, where the joints are in bad alignment. So conservative treatment for these, there's all kinds of padding and gel things that you can stick around the toes to keep them from rubbing. And then certainly you can always fix those. So conservative treatment for bunions and hammer toes includes shoe gear changes, wider toe boxes, more room, mesh toe boxes, things like that, silicone padding, and splinting. One common misconception is if you wear like yoga toes or you wear bunion splints or things like that, that it'll actually fix or repair these things. Unfortunately, that's not the case. This is a mechanical pull problem. So you've got, sort of the reins on the horse pulling in the wrong direction. And so once that rein starts, it's going to keep on going. So unfortunately, once these start, the only way to get them gone is to fix them, but you certainly can accommodate them and protect them and guard them and keep them from getting worse. So there's a lot of conservative things you can try, but of course, fixing it is surgical. So here's a surgical picture of a hammer toe correction. You can see what some of the implants look like. There's some that look like screws. There's some that are made of bone. There's some that are absorbable pins. This happens to be a particular metal kind called a smart toe. It does not make you smarter, unfortunately, so I stopped using it. No, just kidding. So here's an after picture. So you can see this patient unfortunately had a lot of corns. Those are calluses on the top of the foot. And those actually came from rubbing in the shoe. And so after they're fixed, you can see the corn went away because the corn was only the body's attempt to protect that toe from the rubbing. So if you take away the deformity and it doesn't rub anymore, then that corn resolves. So here is Mrs. Walsh's hammer toe surgery. Now, she had, I don't know how to go back. She had a fifth toe. So that picture did not have an implant in it because there was no, you don't put an implant in the fifth toe so it doesn't rub in the shoe. Another common problem is plantar fasciitis. Now, not all heel pain is plantar fasciitis, but I would say the most common cause of heel pain is plantar fasciitis. The fascia is a ligament that runs from the heel bone all the way to the ball of the foot. And so the medial band is here, the one on the inside of the arch, on the big toe side of the arch. And then the lateral band is over here on the lateral, like pinky toe side. And then there's actually a central slip that goes down the middle. The most common, because it fills up the arch here, is the medial band. So if you have pain on the inside of your heel, on the big toe side, and it hurts with first steps in the morning, after a period of rest, and then like you sit for a period of time and then you get back up and stand up and then you start to get pain, that's typically plantar fasciitis. And it is very common. We have a slew of stuff to treat plantar fasciitis with. There is a slide about that in just a minute. Here are some pictures of what x-rays look like in people with plantar fasciitis. These are little spurs that come off the heel. We used to call plantar fasciitis heel spur syndrome. We don't call that anymore because it was confusing to patients, because when you step down, when you have plantar fasciitis, it feels like you're stepping on like a spur, like something like a nail or something, because it hurts so bad. So the spurs though are not growing down, they're growing to the side. And so really they're horizontal to the weight bearing surface. So the heel spur is not the problem. We used to remove those spurs and we're causing more problems than not. So we call it plantar fasciitis now and not heel spur syndrome. So you may have heard both of those terms in your past. Plantar fasciitis, again, I was telling you, there's a lot of different treatments for that. Steroid injection, stretching, night splints, taping, shockwave. The mainstay to treatment is treating the inflammation, stretching the back of the leg, and arch supports. Those are the three mainstays. And so we always start with the easy home stuff when you come into the office, but there's and including shockwave, that now we're doing platelet injections, stem cell injections, and then certainly surgical release if you're stubborn. But we have a whole bunch of stuff to offer with plantar fasciitis. It is not something you have to live with, and it is not something you have to struggle with. So if this is something you've had experience with in the past and haven't been successful getting rid of it, let me know. There is a lot of stuff. And like I said before, not all heel pain is plantar fasciitis. There's other things that can cause heel pain. So if you're having heel pain and you've done all these things and it persists, also let me know, because that's something we can look into. Kids, not all specialists treat kids. That's a sort of specific area of treatment. Most of the stuff that we see with children are their congenital deformities, flat feet, things they're born with, like clubfoot, syndactyly, polydactyly, which is extra toes or toes that are webbed, things like that. The closer you get down south, like in San Antonio, you see a lot of this stuff come up from Mexico, South America, some of those countries that are not quite as advanced with vaccines and things like that. You'll get some of the polio patients, post-polio patients from there. So most of the stuff we see in kids is sports injuries, sports medicine, flat feet, growth plate inflammation, things like that. But we definitely take care of the congenital stuff too, which is a little bit more rare, but certainly things that need to be addressed. I had just as an example, a young man, not even a teenager yet, come in with drop foot, and turns out he's got spinal cord tumor. So sometimes people come in with foot things, and because the foot is the end of the low back, we have to make sure that we're always looking ahead and seeing if there's anything further up the leg that could be causing part of the problem. So again, not a specialty that isn't completely involved with all the body symptoms. Kids have growth plates that we have to be aware of. This is what a growth plate looks like. And it is open line, which is actually new bone cells forming, and it's in all the bones. And so when these are open, we have to be very careful to monitor those in our kids, because that's where the bone growth comes from. So in sports injuries and traumatic fractures and congenital things, we're always monitoring growth plates, and they're just kind of fun to look at on x-ray. They're irregular. So the patients look at them and they go, oh, it's broken. I'm like, no, it's normal. Now, if you're 70, that's not normal. So come see me. Ingrown toenails, really common. Plantar warts, really common. Those are all ages, but really common in kids. Sports medicine is huge, especially here at Texas Orthopedic Specialists. We cover a lot of the high schools and their sports teams and stuff, and some of our active patients. I get a lot of Zumba injuries. That's a big one with a lot of side-to-side cutting, pickleball, racquetball, a lot of side-to-side cutting. So it's a real common cause of tendonitis. But ankle sprains, stress fractures, tendonitis, cramps at night from either nerve or muscle fatigue. And then certainly shin splints is a real common one, which is the inflammation of the anterior muscle on the leg. So we do a lot of sports medicine here. I would say probably my most common are fractures from falls and from injuries, football, things like that, the more violent sports. And then certainly ankle sprains. Probably had 2 or 3 of those already this morning. So those are really common. Again, there are a lot of common foot and ankle stuff. These are probably a highlight of what I saw today, just in general. I had a question come in earlier already, so I'll answer that one first. And it's a gentleman that had a significant history, but also some low back stuff, and was worried about some ball of foot pain. One thing that's not on here that is pretty common is in this area of the foot, this ball of foot, when you have pain here, there's a couple of things. If you've got any big toe joint issues, bunion, arthritis, limitation of motion, old gout stuff, whatever it might be. If you've got a limitation of motion here, this little guy gets overloaded and it's capsulitis or inflammation of the second toe joint. So that's a common problem of ball of foot pain. The other one is a neuroma, and that is the nerves run in between all the long bones of the foot and branch and go to the toes. And the nerve on the bottom gets pinched in between the two knuckles here and causes ball of foot pain and pain into the two associated toes. So if you have ball of foot pain associated with two toes, typically a neuroma. Ball of foot pain associated with one toe, usually capsulitis. But the question I answered that I received earlier about the ball of foot pain, especially barefooted, because that nerve is on the bottom, and then you put shoes on, it's a little cushion, that can help, but barefooted can exacerbate it. Being up on the ball of your foot, reaching ahead of you to kind of grab something off a shelf, all of those things can increase pain there. But those are the two most common ball of foot pain questions. For neuromas and capsulitis, they're treated a little bit similarly, and I use some padding with or without a steroid injection or some anti-inflammatories. So certainly something that can be treated pretty easily in the office. There are some alcohol injections that I do for those too to kind of shrink and kill the nerve. So neuromas also can be removed, but I typically don't have to remove neuromas much anymore because we have a lot of good conservative treatment. So the question that was emailed earlier about the ball of foot pain, it sounds like you might have a neuroma. If you've got a low back history though, and you're having nerve pain, it's always best to see somebody about a nerve conduction test to make sure that that nerve pain isn't the sensation from the nerves in the low back that you're just feeling in the ball of your foot. So without a low back history and with a good physical exam, you usually can tell the difference between a neuroma and then just nerve pain from the low back. But those are the two sort of differential diagnosis I would give that gentleman to answer his question. Aside from that, like I said, I wanted to get through that so you guys could kind of go back and ask questions about any of those things or anything else you have, nail stuff, skin stuff. If you've got any questions, I'd be happy to answer all of those. So Terry,
I wanted to mention that gentleman's name was Don, and I appreciate you answering that. He emailed me that question, and I may not be able to look at the questions just because of my login, so I'm going to come back in there in a second, but I have a question for you while I figure out how to get back in there in just a second.
Okay.
In terms of ingrown toenails, is there anything you can say about that in terms of care for it, or should they just come see you, or?
So ingrown toenails is also a really common problem. I would say 50% of the ingrown toenails that I get when people make an appointment for an ingrown toenail is actually a nail fungus. Nail fungus actually looks like a nail that's thicker than it used to be. It can have some discoloration to it, whether white or yellow, flaky, but typically it can just be thicker than historically it was. And so the thicker nail, sorry. There. Okay, is this, I'm
That's a
shared
question.
screen, so is this all up on the screen then? Yeah.
So maybe
That's
if you
okay.
can keep it in
I
there.
can scroll it. Yeah.
Sorry about that.
Do you know how I can go back on the slides in case anybody has a question about one of the
Yeah,
slides?
you'll just have to click on it and
Go through it again.
yeah, just hit you can click on it and yeah, and just start over.
Okay,
There.
perfect.
Okay.
Thank you. I just didn't know.
I'm so sorry.
That's okay. Thank you. I'm going to go back. So anyway, if it's a true ingrown toenail, it's where the nail sort of curves in and digs into the skin. And so those can actually be treated and removed in the office. But I would say 50% of the ingrown toenails that I get are actually from nail fungus. So if you've got a nail fungus and the nail is just thicker than it's supposed to be, then if you don't treat the nail fungus, you'll be digging that thing out and having procedures and all of that, and it really doesn't make a difference. So if you just had a bad pedicure, you trimmed it, and it's a little bit ingrown, soaking in warm water Epsom salt is a good treatment. It gets rid of the inflammation around the skin, lets the nail grow a little bit, gives it time to grow a little bit. But if after a few days that isn't relieving it, please, yeah, come in, because a lot of times it's not just the ingrown toenail. There's always other things that can be the cause of that ingrown. So I would try the warm water Epsom salt. But if the nail fungus is part of the problem, if you don't treat the nail fungus, you're going to be dealing with that probably forever. So I hope that answered your question.
Thank you. Do you want to go ahead and go through that question you saw on there? I cannot pull it up on my end, unfortunately.
Yeah, that's okay. It was an ingrown toenail problem, so I think I covered it. Yeah.
Awesome.
So if anybody has, yeah.
Well, I was going to ask about arthritis and foot pain. Is there anything people can do for arthritis in their foot, stretches or anything like that? And
Arthritis in the foot typically is either in the midfoot here or in the big toe joint. So if it's in the midfoot, there was a medication that was prescription only. It's called Voltaren or diclofenac, and it's over the counter now. And so it is great for arthritis of the feet, and it's great for arthritis of the hands because all the structures in the hands and the feet are superficial. So you can rub that in and it works splendidly. If you've got arthritis in the midfoot, my suggestion is prescription insoles or soft insoles to support the midfoot arch, and then the Voltaren. But big toe joint arthritis comes in stages. And so if you've got big toe joint arthritis, there's other things we can do, injections, orthotics, and certainly surgery. Surgical procedures for arthritis in the big toe joint vary. It depends on how advanced the arthritis is. And then surgical procedures in the midfoot arthritis are fusions. And that sounds severe, just a fuse something willy-nilly, but the midfoot is actually a stability joint. It's not supposed to have flexion in it. And when you get arthritis in the midfoot, now you've got motion where you're not supposed to have motion. And so the fusion is actually a restorative procedure to get that midfoot back into the condition it was supposed to be. And it works really well. It just depends on if you're able to do the recovery. The recovery for some of those surgeries can be several months, and so the first few weeks are usually like on a knee scooter or something, not always, but so the biggest deal is making sure if you do proceed with surgery that you're able to do the recovery. But again, conservatively for arthritis, there are some topicals, steroid injections, and then certainly insoles with some accommodations depending on your foot type to sort of help manage it. Yeah.
if you see any more questions pop up, feel free to answer them, Dr. Suttle, on that questions tab. Did you mention when you talked about ingrown toenails about toe clipping and cutting or toenail clipping tips or anything like that? I think a lot of people get concerned of how to do it properly or, go to the local
pedicure place.
salon, and I don't know how you feel about those types of places.
So it depends on your health. I mean, I don't really recommend them anyway. There's a couple of places that I do recommend to my patients that don't have the jetted tubs, which is where yeast and molds come from. And that's where a lot of nail fungus comes from in women. The yeast and molds are in the water. So even if they're sterilizing stuff or putting baggies in the tubs and things like that, it really doesn't have anything to do with the molds and yeast that are in the water. And so then they paint your nails, and then that yeast and mold that gets stuck between the nail polish and the nail, and that's where the nail fungus typically comes from. So there's a couple of places that I recommend to my patients, and if anybody wants the names of those, they can certainly email you, and I'll be happy to give them that information. But the pedicure itself isn't a problem, but if they're not using clean implements and they're not using non-jetted tubs, then typically that's where I've had secondary bacterial infections and nail fungus come from pedicure places. The other thing is if they try to kind of curve the nail in or dig in around the skin, I get a lot of ingrown toenails. I had one yesterday morning that she had gotten a bad pedicure, and the nail tech had clipped the edge of the nail but didn't get the whole thing and left a hook, and it created an ingrown toenail. So pedicure places, if you have a good tech, they are fine. But if you have somebody that doesn't know what they're doing, they can create quite a problem for you. So I recommend a couple of places for pedicures. Certainly communication with the esthetician or the technician is key. If you don't feel like you can explain to them your needs, or if they're hurting you, or if there's pain involved and you can't explain that to them, then you need to go someplace where you can communicate with the person that's trimming your nails. If you have diabetes or peripheral arterial disease, or if you have any kind of open wound on your foot or ankle, you should not go to a pedicure salon. I actually see patients with diabetes and other systemic arthritis and arterial disease for skin and nail care every 6 weeks, every 12 weeks, depending on their needs here in the office, and insurance does cover that. So for certain diagnosis, if you need skin and nail care, I do that in the office. And so that's much safer than paying a pedicure place to do it and then getting some sort of secondary infection, because the payment for that could be the loss of a limb or a toe or something. So very important to make sure you're taking care of yourself in that manner. Very good question. Thank you, Terry.
Oh, you're welcome. I always have lots of foot questions. Is there any point where people should, I know you said while you were talking about if it gets to a certain point, come see you. Anytime they have foot pain and it's so much that they can't bear it, that's when they should come see you, or,
You should not have
anytime.
foot pain. I mean, people think, oh, well, I live with a little foot pain. I mean, pain is one thing. Like if you're on your feet all day and you've had a long day and, you maybe have a little swelling, or, you've just been standing for a long period of time, achiness, soreness that relieves itself when you sit down is normal. Usually you can change your shoe gear, do some things to help even with that. But foot pain is not normal. Now, some people have end-stage arthritis or end-stage issues that we are managing, and they may live with a 1-2, but that's because they've got a chronic condition that we're managing. But if you just have pain all of a sudden and you're like, well, guess that's me now, my feet just hurt, you should not live with foot pain. So if you've got something that hurts and you're not sure what it is, it's always best to get it checked out, because there could be something super easy that we use. That's one of the favorite parts about my job. Like there's something super easy we can use that you walk out of the office feeling better. I mean, there are some things that I dispense and people are walking down the hall like, oh my gosh, this is what I needed. And it's just because you weren't sure what was going on. So you're trying some things. They may help a little bit, but not getting rid of your pain completely. It's just knowledge. Knowledge is power. And if you know what's going on, there are usually a lot of little easy things that we can do to make that go away. And I always tell people, foot pain is not normal. You should not have to live with foot pain.
Perfect. And do you have any last remarks, or do you want to check and see if there's been any more questions?
Yeah, I didn't see anything else pop up. I'm not sure if everybody's able to ask questions on this or not. I'm sure they are, but if certainly if there's something specific to you or something specifically going on with you and you want to see me, just give our office a call. I'll be happy to. Sometimes our foot stuff, we want to talk to somebody in person. I'm very, like I said earlier, I wish I could, look around the room and see hands raised, and I'm more comfortable in person, and sometimes doing a full exam on somebody and making sure that we're checking everything out is also important. So if you have any issues or you want to be seen by me, just give our office a call, and I'll be happy to take care of you. But again, there are lots of common things that people live with and don't realize that there's easy stuff that they can do to fix it. And so really I wanted just more of a question and answer forum for you guys to ask questions. And so if you heard this and we're having trouble asking the question in the little box for the webinar, just feel free to email Terry at the email that, is there an email, Terry, in the?
My email? Yes.
Okay.
So reply to my email, you all have it, and I will always forward all those questions to you, Dr. Suttle.
Yep. And so if you just want to email me your question and I'll answer it, and we'll email you back, and I'll make sure I read all of those and answer your questions accordingly.
Yes, and this video will be available on YouTube. So if you had any issues with audio, or if you had any issues with the video portion or anything, we will be posting it here within the next couple of hours. And if you want that link, I can email it to you. So just email me, Terry Armstrong. It should be available to email through the GoToWebinar email you received. And I had a slide to show you all our contact info, but that's okay. So txortho.net. Texas Orthopedic Specialists, Dr. Suttle sees patients in Bedford and in Keller Alliance, so whichever location is convenient, she can see you there. And want to thank Jenny and Texas Health Southlake for joining us on this webinar. And I think that's about it for us. Anything else?
No, thank you guys for logging in and listening. And again, if you had anything that you wanted to ask that you didn't get to ask here on the webinar, because like we have technical difficulties, I log into a lot of webinars and I try to ask my question and it didn't get answered, and so it's frustrating. So feel free to call us or get with Terry, because I want to make sure that that was the meaning behind this and sort of the intent behind this webinar. So if you guys need anything or have any questions, please just call us or email Terry.
Thank you for pulling that up. And one more plug, Dr. Hale, one of our hip and knee replacement specialists, he will be doing a talk through this GoToWebinar platform for the Southlake Senior Center on Friday, September 4th from noon to 1 p.m. and you should be looking for that in your newsletter this Friday, I believe. So hopefully we'll get all the kinks worked out, and you'll be able to just easily watch that one. But that's again on Friday, September 4th, and we'll send you the information via your newsletter this Friday, I believe. Okay, well, thank you all so much, and I hope you all have a wonderful day.